Well, I think it's 7:15, so we will go ahead and start. I'm Dr. Lewis Hassel, and I welcome you to our session. We've titled this Sign Out with the Professor, but I am going to try something a little different today, and perhaps in the future, we'll make this a little bit more interactive because I have figured out now how I can share with you the slides in advance that we will discuss. Today, I'm just going to share from my screen, but please feel free to ask questions either in the chat box or to raise your hand and unmute yourself to ask a question as we go along. I do not object to being interrupted, and I will also try to pause and allow questions as we go along. So I'm going to share my screen now with the digital slides. I have posted the link to these digital slides in the chat box. So if you want to copy that link, you can observe and study the slides at your own pace now or later on as well on your own computer. So here is the screen with our first case. This is obviously from the colon. The patient was undergoing a screening exam, about 55 years of age. They come for screening for carcinomas and precursors of carcinomas. As you see, this is several fragments, and this was a fairly large polyp that was sectioned into 6 different sections. We'll start here with the smaller sections. As you can see, we have an architecture here that shows a little bit of an abnormal configuration. We see that the epithelium here along the surface shows these undulations or indentations that are characteristic of what we call the serrated pattern. And with serrated pattern polyps, we become concerned about the possibility of either serrated adenoma or serrated lesion, or possibly a hyperplastic polyp. Now, this is a fairly large polyp because you've seen that it's in several different sections. And so that alone would be helpful to distinguish it from a hyperplastic polyp, which is usually less than 5 millimeters. The other feature we see here is we have some indentation. And as we look at these deeper crypts, we see here's one that's dilated at the base. Here's one that started to grow laterally a little bit. And so when you find one dilated crypt or one with lateral branching at the base, that is considered sufficient to make the diagnosis of a sessile serrated adenoma. So are we done with this case? Well, we've only examined half of it. Here's another dilated crypt there. And there's another finding here as we get to the larger fragments. And that we will see as we come into focus here. Notice here that we can begin to appreciate a change in the coloration of the cytoplasm. If we look here at this polyp right here, the cytoplasm is partly vacuolated, partly pale pink. As we look over here, it becomes a little bit darker pink. And we also see that there's more nuclear content. So the nuclei have become larger and they become stratified. So what's going on here? Well, there are a couple of possibilities. One is that this is developing into a traditional serrated adenoma. And here we see one of the features of a traditional serrated adenoma, which are these little, what are called ectopic crypts. And these little morphologic changes are one of the hallmarks of a traditional serrated adenoma. And traditional serrated adenomas can have a more villous architecture, as we see here as well. Here is still the serrated pattern of the epithelium. But what is more perhaps important is this increase in nuclear material and the sort of crowding of these nuclei, as opposed to being very basal and small, as we see over here in the upper right corner. These nuclei have moved up in the cytoplasm and they become more elongated and more pencil-shaped, which is more characteristic of an early stage of dysplasia. So that becomes the consideration. If this is a serrated adenoma of the conventional sessile serrated adenoma, it is becoming dysplastic. And it's also beginning to manifest some of the features of a traditional serrated adenoma. We'll go and look at this last piece here. And again, we'll see this change has occurred here. And here, rather than being very villous, it has more of a tubular adenoma type of pattern with these darker nuclei stratification. The nuclei become what some people call pencil-shaped rather than rounded. And so this lesion then should be classified, I think, as a serrated adenoma with areas of dysplasia. Now, that's conventional dysplasia. The sessile serrated adenoma, of course, is a precursor lesion to carcinoma. But certainly once we develop conventional dysplasia, as we see here, that risk becomes a little bit higher. So let's go on. Any questions about that case? We'll show you just another example here, but I'll pause for questions. Anyone have any questions? Feel free to speak up. Okay, well, not hearing any, we'll go on to another case. Welcome those of you who joined us later. We're using digital slides today so that we don't have the focusing problem that we've had in the past. So this is another screening exam. This patient had a history of polyps of a variety of types. And this polyp, again, we see at low magnification has this serrated pattern epithelium. And then we also see that here on the edge of it, it starts to lose that pattern. You see here we've got serrated epithelium here, and then we lose that pattern and it becomes more, these glands are a little darker. You can see the tint change in the more nuclear bluish color in these glands compared to the normal epithelium here. So seeing this pattern with a serrated pattern polyp with what looks like it may be dysplasia, do I need to worry about whether or not this is a hyperplastic polyp? Really, I don't, because hyperplastic polyps, by definition, do not progress to become dysplastic. And so I can call this a serrated adenoma with dysplasia based just on this low magnification view of seeing the serrated pattern next to what appears to be a low-grade dysplasia. Now, we can look here a little further and say, oh, well, here is a dilated deep crypt, so maybe we would call it a serrated adenoma if we just had this part of the lesion. And that's true. I want to also focus here a little bit on this dysplasia because this is a very subtle dysplasia. Certainly, if you had just a biopsy with just this field, it might be difficult to determine that this is dysplasia. And so it's very helpful that we have this adjacent normal epithelium or more normal epithelium to compare. And as you can see, the cytoplasm changes, the cell size changes, the amount of nucleus changes, the location of the nucleus begins to change, and the shapes of the nuclei begin to change. So here in these normal crypts, the nuclei are all small and definitely pushed towards the base of the cell. The goblet cells are present, and they're fairly large goblets. Whereas over here, you see these nuclei are probably 2 to 3, maybe 4 times larger than these benign cells here, these benign glands here. So this is dysplasia, and you can compare that just in this screen to see that. The other thing here is we have lost the serrated architecture that we had here. So this comparison side to side in our lesion helps us to define the nature of this lesion as a serrated polyp that has become dysplastic. Now, this is not very common. We don't encounter this very frequently. We certainly see dysplastic tubular adenomas very frequently. We see frequently serrated adenomas, serrated polyps, but we don't see frequently the combination of these two findings together. That's maybe a little bit why I selected this case, because it's just a little bit out of the norm for what we would expect to see. So we're going to continue on and talk about some other lesions in the GI tract. Our discussion today is centered around GI lesions. This is a patient who was about 60 years old, and he had a history of Barrett's esophagus, and he had been previously endoscoped, and his Barrett's esophagus was sufficiently severe that they decided to do a radio frequency ablation. And I have a video covering this process in my file of videos, which you're welcome to take a look at. But so this is now a follow-up exam of this patient following his radio frequency ablation. So we have several fragments, or good-sized fragments with a little bit of muscularis. So this is a endoscopic mucosal resection, which indicates that the endoscopist saw something that he was concerned about could be neoplastic. So we'll focus first on this area here, where we see mostly just nice squamous epithelium, but then a little island of something here. And I suspect that this was probably what the endoscopist saw, was a little residual focus of glandular epithelium, a little bit different tinctorial quality. So this area, we see we have columnar epithelium. Can we define this as residual Barrett's? Well, as we look at this section, we see just a couple of clues that this is a Barrett's. So here we have a couple of cells here that look like they could be goblet cells. And then here, another one over here, maybe something here. So there's a little bit of glandular epithelium with the suggestion that likely this is Barrett's esophagus residual here in this little island of tissue. Now, is there dysplasia here? We don't see significant atypia here in terms of surface epithelium, but we do see, a little bit of glandular complexity, but nothing that looks like dysplasia. So this gland is a little bit atypical because you've got this sort of more cribriform architecture. But I don't think I would have called this alone as being dysplasia. But one of the complications of radiofrequency ablation is that the surface can get damaged, but the tissue that is remaining in the deeper tissues can still harbor either Barrett's or dysplasia or carcinoma. And that's why I want to focus now on this area, which we dotted with a little green dot at the time of initial evaluation. So here we see an intact squamous epithelium, and we see several clusters of glands in the deeper tissues. Now, as we look at these tissues, I don't see any goblet cells. Maybe a little suggestion here, but nothing definite. But what I do see is a variety of sizes and shapes. So here's a gland that's very small and it's quite dark. Here's another gland that has more or smaller cells, more cuboidal appearing. But I also notice that this gland has strands of smooth muscle on one side, on the other side of it as well. So I'm a little concerned that this is a gland that is in the muscularis mucosae, which is not where I like to see them in a patient who's had a history of Barrett's esophagus. Here is another very concerning finding here in this cell group. Notice this is a solid nest of epithelium. The nuclei are fairly atypical, and we have sort of this loose blue stroma around it, a little bit of a desmoplastic type response. And then, of course, we have the vasculature here that's prominent. Looking at this gland here, again, we see fairly low cuboidal cells, but the nuclei are fairly variable. Their nuclei and the NC ratio is very high. And in addition, in the lumen here, we have cellular debris. I always think that that is a concerning finding in a potentially pre-neoplastic or neoplastic lesion, that the presence of cellular necrotic debris does not bode well for that patient. And then finally, this group over here, more concerning findings. One is this gland right here, very tiny gland with just very peripheral cells. Now you might say, well, that's an endothelial cell, and it possibly could be, but even just this size gland is very abnormal. And then here we see more of these. And in contrast, see, this is probably a true gland, because all the vessels here have either red cells or other things in them, and these do not. I think these are true microglandular buds off of this lesion. So finding this sort of thing, and here's another concerning finding, a mitotic figure in this gland, the abnormal architecture here accentuated. So in a patient who's had a history of Barrett's esophagus and has been ablated, finding this constellation of features in deep tissues, potentially beyond the muscularis mucosae, is very concerning for dysplasia, plus or minus potentially intramucosal carcinoma. So we would sign this case out as residual Barrett's esophagus with foci concerning for intramucosal carcinoma deep to the squamous epithelium. Now, this poses a real problem for the endoscopist because they probably can't see this as they look from the surface outwards. And so this presents one of the challenges in follow-up of these patients. And it is one of those complications that can occur with radiofrequency ablation of these lesions. So any questions about Barrett's esophagus, about our interpretation of these findings in this case? All right. We'll go on to the next case then. This case, we have two slides on this case. This is a 44-year-old patient with a history of, I think, chronic gastritis, who now has some polyps and a mass in the stomach. And here we see a low magnification of one of these. Now here, what do we see here? This is the normal mucosa here on this edge. And then we see this proliferation of a mixture of, I see a mixture of foveolar type epithelial cells, and this loose stroma. There's some dilatation of these glands, but they're not distended. So although these are large spaces, they're not tensely distended. So there's still some undulations of the surface. They're not rounded cystic structures, which is an important consideration. And as I mentioned, we want to look and see what kind of epithelium we have here. This is all pretty much foveolar glandular surface type of epithelium. We also have a mixture of inflammation in the stroma, which is very loose, and we don't see any definite smooth muscle in this stroma. So an edematous polyp of this sort, and we'll look at the next slide, which also is the same patient. Here you see a little bit busier situation, maybe a little bit more dilatation. And here in this gastric polyp, we can also begin to see that there's more areas of epithelial predominant growth and so forth. And we'll just take a look at some of these areas because we also want to pay attention. In many gastric polyps, we have the risk of developing dysplasia, just like we talked about in the colon. And so we'll compare here what's going on in some of this surface epithelium. So here we see some complex growth, a little bit more of a proliferation. And then over here, we begin to see, again, this complex architecture, which we have seen in other locations. And this kind of a pattern is not acceptable for a simple uninvolved benign polyp. So seeing this kind of cribriform architecture with loss of the foveolar typical mucin, as we see in these other glands, this should again raise concern for dysplasia. And in fact, this is what we would term a hyperplastic polyp of the stomach. Now, I didn't make up the names. This is the real name. But we have here areas of dysplasia in this polyp. We can look at other areas as well, and we don't see dysplasia. So it's very focal. Even down here, looking at this more architecturally complex area here, we can see that here we've preserved the cytoplasmic mucin. We have certainly a complex architecture, but we don't have that intraluminal complexity. Only as we get to the surface here do we begin to see maybe a loss of some of the cytoplasmic features and a little bit of hyperchromasia to the nuclei that would raise concern for dysplasia. So those are the points I wanted to make on this case. Hyperplastic polyps are typically of foveolar type epithelium. They have a very edematous stroma. They may have some glandular dilatation, and they tend to have a somewhat undulating, branching, type of surface. And they may have some cystically dilated glands. So our sign out on this was a hyperplastic polyp with areas of dysplasia. And that's important because these patients do then present an increased risk for development of carcinoma. It's only maybe less than 1% of these patients who will develop that, but having recognized that, that's important to provide for follow-up. So here is another example of a mucosal hyperplasia in the stomach. And here we don't see that same degree of edematous stroma. We just see a predominance of hyperplastic foveolar type epithelium. Again, we see little areas where it's a little bit darker. We'll come back to these. We can see the complexity here. Here we see a little different change, this more eosinophilic cytoplasm, a little paler, different staining characteristic. And I apologize for the dirt on the slide. This is not my slide. I did not do the scan on this slide. Now, in this polyp, you'll see that we also have some of these deeper antral type glands as well, sort of the mixture of things. So these lesions can occur both in the body and in the antrum, and can preserve some measure of the underlying mucosal glandular tissue. Well, it looks like a few other people are using here, so we're slow to focus. Let's go to here some of these areas where we have the dots. This is to help us key in on these things. And as we look at this particular area, I think you'll see why this was dotted. So here is the area of concern. And you can see the contrast between this more normal foveolar epithelium here and this more complex and atypical epithelium, where you'll see these nuclei have actually become quite dysplastic. They are coarse chromatin, prominent nucleoli, and the architecture is altered. So this is, again, an area of high-grade dysplasia or potentially even intramucosal carcinoma, because it has lost that characteristic architecture and cytology that we would associate with a more benign lesion. So here we have a focus of dysplasia, and as we look at other areas here in this patient as well, we'll be able to identify some additional findings here. Thank you for those who continue to join with us. I hope you're not having troubles getting in. So here again, we see this abnormal cytology, just a very localized area, but notice how the architecture has shifted somewhat. And here it begins to be more concerning for intramucosal invasion. Now, this is important because, as you know, in the stomach, we stage cancers, in situ cancers, as T1A. The stomach and the esophagus are staged differently than in the colon. So while seeing dysplasia in a colon polyp is concerning, in a gastric polyp or in the esophagus, this becomes a T1A cancer, and therefore it gets a little bit more serious attention from our colleagues. Okay, so I think that's all I want to say about these hyperplastic polyps with dysplasia. Are there any questions about that? If you want to write your questions in the chat, you can do that as we go along, and I will try to pick those up and answer them towards the end. So let's go on to another polypoid lesion. This is in a younger patient, a 35-year-old patient who had a polyp detected in the duodenum. And so as we look at this polyp at low magnification, we see, you know, it's really quite branching. It's kind of got nodules. It's kind of hard to tell the top from the bottom or the leaves from the tree. It's got a very serpiginous pattern. As we look at the mucosa here, I think you can appreciate that this looks to be a villus type of small bowel mucosa. Here in the crypts, we can see Paneth cells, so that fits with the normal mucosa. Here we see villi, a lymphoid stroma. So the epithelial component of this appears to be a fairly normal epithelium. It's just the architecture is altered. So in this situation, seeing everywhere kind of normal mucosa, normal components without dysplasia, we would begin to think about the more hamartomatous type of polyps. And in that category, there would be probably 2 or 3 polyps that you should think of. One would be juvenile polyps, and another would be Putz-Jaeger's polyps, and a third one might be the Cronkite Candida type of polyp. So what distinguishes them? Well, very helpful to come back to low magnification here. And we see that there's this sort of branching, arcading pattern of smooth muscle in the stroma here. So we'll go to higher magnification just to verify that this is indeed smooth muscle here. And as we come into focus, I think you can see that this is a smooth muscle here. As we come over here, we see this is a strand of smooth muscle again. Please come into focus here. There we go. Yeah, so you can see that this is smooth muscle here. And so that is an extremely helpful defining feature of the Putz-Jaeger's polyps, is that they have a very characteristic branching, or what's called arborizing architecture of smooth muscle that underlies what's going on with the polyp. So when you see that kind of branching pattern, when you see normal mucosa, hamartomatous type mucosa, you can say almost immediately, this is a Putz-Jaeger's polyp. Now, important to recognize that these Putz-Jaeger's polyps can occur anywhere in the GI tract. Really, they can occur in the esophagus, in the stomach, the small bowel, the colon, anywhere along the path they can be seen. So with that, let's just show another example here. And this is one where you might look at this and say, okay, well, here again, we have this sort of nodularity, and we have a little bit of inflammation, a little bit of things. We look at the mucosa here, and what we see is this very mucinous type of mucosa, sort of a foveolar type of epithelium. And this was a polyp from the stomach. So we've got foveolar epithelium, and then here we see this arborizing, branching pattern of strands of smooth muscle between the lobules of the polyp. So again, it's a Putz-Jaeger's polyp, this time in the stomach rather than in the small bowel, with these arborizing strands of smooth muscle and a benign or bland epithelium that is typical for the organ where it has originated. Now, why we don't have, antral glands or parietal cells and chief cells and so forth in this polyp, I don't know. That is uncertain to me, but normal component of the stomach. Let's show one more example here. This is a patient who presented with bowel obstruction. And here there's a complexity, again, it's small bowel obstruction. There's a complexity, and we'll focus on this part later. But let's look at the exophytic polypoid part here. Because again, we can see this central core of smooth muscle extending up into the polyp. Again, this is in small bowel, and we see normal small bowel type mucosa associated with this. So a lobulated pattern of small bowel. And that's present through all the exophytic portions of the polyp. Now, what we have down here raises some other interesting questions. So here, it looks like we have a vessel. And in this vessel, we see there's some organizing thrombus. So there's a vascular component to this as well. Here we see another large vessel associated with this. And then we have these glands that appear to be in a place we don't like them. You know, they're in a deeper location. So initially, you might look at glands like this and go, gee, these are glands that look like they may be invading. Is this a cancer that's associated with this lesion? But as we examine these glands and as this tissue, you'll see that this is very bland. This is a very banal type of epithelium. The nuclei are nicely behaved. They're all at the base. There's still a little bit of mucin in the cytoplasm. And we've got some debris here because some of these are cystically dilated and some hemorrhage, but we don't have high-grade atypia. We don't have a desmoplastic stroma that we would associate with a true invasion. So these are displaced glands, and there's this associated vascular change, which may be, in this case, part of the hamartomatous growth, that it has induced some vascular changes. These have become thrombosed, and associated with that, these glands have become displaced downward into the wall of the duodenum. Alternatively, this could have been occurring at a site of a diverticulum, and the Putz-Jaeger's polyp just sort of got caught up in that process. All right, so that's enough for Putz-Jaeger's polyps. Let's go on to talk about a different polyp. This, again, is, as we see, is a nice rounded polyp. And here we see some features that would suggest the kind of gastric hyperplastic polyp, except that this polyp, as I think we can see here, is occurring in the colon. So here's colonic type mucosa here. And so the gastric hyperplastic polyp is kind of off the table with this. In the colon, this type of polyp with a loose edematous stroma and these dilated cystic glands here should make us think about a juvenile polyp. If this were in the stomach, it would be very difficult to distinguish, I think, from that hyperplastic polyp that we just saw earlier. But in the colon, this lesion is clearly a juvenile type polyp. And the features of the juvenile polyp are cystically dilated glands deep in the stroma, which is very loose and edematous. So this pattern is characteristic of a juvenile polyp. Now, some people might look at this and go, well, this could be an inflammatory polyp. But inflammatory polyps usually do not have this degree of glandular dilatation, and they tend to have more of an ulcerated surface. Now, we do have some surface erosion here as well, but the overall features, I believe, favor the juvenile polyp. So that's just to give you an idea of the other hamartomatous type of polyp. Now, juvenile polyps do have a very low, but not, so very low and uncommon development of any dysplasia in these polyps. All right, so let's go on then to look at another example. This is another example of a juvenile polyp. This one, again, occurring in the intestines. I believe here we're in the colon again. And so this one may be a little bit harder to tell because we might look at this and go, well, do we have arborizing smooth muscle here? I don't think we do. I think this, although this looks a little bit like smooth muscle, I'm not sure that it is. But that would be the differential here, is between a juvenile polyp with this cystic glandular dilatation deep and a Putz-Jaeger's type polyp. But I don't think we see really well-developed smooth muscle out into this. It doesn't have quite that same lobularity. We see the inflammation, and we may even see here a little bit of a area beginning to be concerning for dysplasia in this polyp. As you can see here, we begin to get a little difference to the tinctorial character of the epithelium, and the architecture changes just slightly as well. So these polyps you do need to consider and evaluate for dysplasia, as we have with the other polyps that we've looked at today. Okay, we've got a few more minutes left. Let's see if we can get through another case or two. This is just a little trivial case. This is a patient who had a small bowel mass and had some pain along with that. And on exploration was found to have what looked like a outpouching from their distal small bowel. Here we see on the mucosa that we have ulceration. Now over here we can see that we're in normal small bowel mucosa. And as we come into this area where we have the ulceration, that mucosal pattern changes, and instead of small bowel type mucosa, we can see that we have begun to see here gastric type mucosa. So here are sort of antral type glands. We have as well some chief cells and parietal cells here in a few areas over here, as you can see here nicely. A nice mix of sort of gastric fundic type glands. So here we have ectopic gastric mucosa in the small bowel. The real kind of gem to this case, however, if we can come back out to low magnification, is what was located in the submucosal tissues of this area. Okay, here we go. Right over here, we had this little area of bluish tissue as well as part of this diverticulum. And as we look at this sort of nice lobular pattern architecture, we can detect at low magnification these slightly pale geographic areas and this more amphiphilic tissue. We see this is organized in a pattern that is very reminiscent of the pancreas. Here we have ductal tissue, we have acini, and quite remarkable for ectopic pancreas is the fact that we have islets as well. So this is a Meckel's diverticulum with ectopic gastric mucosa and with an ectopic or supernumerary pancreas with islet cells. So that's kind of a spotted pony for sure in terms of abnormality of findings. So we've covered a large number of gastric and polypoid lesions of the intestines today. There were a few other cases that I've included, but I think we'll stop now for the time being and answer any questions that you have. Thank you so much for joining me. I have recorded this session, so it will be available online, and I will post the link to the digital slides so that you can come back and look at those at your leisure, maybe even share them with your friends and show off your knowledge of gastric polyps that are not commonly encountered. Let's see. All right, well, I'll stick on for a minute or two and see if there are any further questions, but if not, thanks so much for joining me, and we will do this again next month. Next time, I'm going to send you the link and post the link to the slides in advance so that you can actually study them ahead of time if you'd like. So thanks so much, and we will see you next time.